So what kind of happens just from that hormone perspective when we start to reach perimenopause and when we start to go into menopause?
Yeah. So much.
Yeah.
So much.
Everything.
Everything. But, as a fertility perspective, I sort of say, well, the ovaries get less predictable,
Yeah.
and there are fewer good eggs. No matter who you are, the most you can ovulate is 12 to 13 times in a year. And when we're 25, most of those eggs are going to work just fine. When we're 45, maybe one, and there's just so many things that have to go right to conceive.
I'm Jessica Vallant. I'm a physical therapist, women's health expert, and Pilates teacher, and my goal is to help all women feel strong, safe, and secure in their bodies. In this podcast, I'll share expert advice, facts, amazing guests, stories, compassion, and hope to help you meet your body in all seasons of life. I am so excited about this conversation today with Dr. Lora Shahine. So I met Dr. Shahine online through some mutual acquaintances, and we immediately kind of struck up a friendship. I have the ultimate respect for her. So as someone who has been through IVF and can say it was a very, very hard and frustrating and scary time. And I had so many questions. This was 8 years ago, and there wasn't a lot online about it. I didn't have many friends who had been through it. I didn't have very many hopeful resources. And seeing what Dr. Shahine posts now, what she talks about, her passions, I wish so much that had been available to me back then. And I refer so many people to her resources who are going through infertility, miscarriage, anything in that realm. She is an amazing resource for education and just for hope and encouragement. So let me tell you a little bit about her. Dr. Lora Shahine is a double board certified OBGYN and reproductive endocrinologist practicing at Pacific Northwest Fertility in Seattle. She is dedicated to educating on reproductive health as an author, speaker, content creator with over 1 million followers across YouTube, Instagram, TikTok, and other platforms. And the host of the Brave and Curious podcast. And I'll tell you, not only that, but Lora also sees patients in real life. She is a clinician. She is a mom. She is doing so much good for so many of us out there in this conversation. And we really dive into a lot of topics around infertility, including toxin exposure. It's a passion of Lora's. She has some really great advice around that, around endocrine disruptors. We talk about the IVF process. We talk about freezing eggs, if that's something that might be in the future for you. It's just a really robust conversation, again, full of expertise and facts, as well as the compassion and the hope and the empathy that you get here from both myself and the experts that we bring in, so that you know you are never alone. So thank you so much for being here. I hope you really enjoy this conversation with Dr. Lora Shahine. All right. Thank you all again so much for being here. You guys heard all about Lora in the intro. I have known Lora, I think it's like 2 years now probably, that we were introduced through like mutual business people that we worked with. And you guys, I'm not kidding. You have to go follow her on social media and everything. I'm so, so happy to have you here. If you all need a resource online, not only for IVF, but everything we're going to talk about here, but really if you need to be just seen and heard during that time of life, this is who you need to follow. Mm-hmm. I went through IVF 8 years ago now. And I know that if you had been in my sphere at that time, it wouldn't have been such a hard time. So thank you for being here, and thank you for everything you do for women. It's so important.
Oh, Jessica, thank you. I just appreciate that so much. And I am so happy to reconnect with you and really grateful to be here.
Yeah, I'm so excited about our chat today. I know it's going to be great. Why don't you tell everyone what they should know about you, whatever part of your story that you want to share, let us know.
Wow, I love that. I Gosh, I mean, you could go back to growing up in a relatively small town in North Carolina and ending up in DC and California. And my family still thinks it's wild that I'm living in Seattle, but I absolutely love it here. And this is where I'm raising my family. And people often ask, how did you end up in fertility and doing
Yeah.
IVF? And I just was one of those big nerds in medical school that loved everything that I was doing. And I really enjoyed women's health and surgery. And the very last rotation that I did was OBGYN. And I was like, someone made a field for me. Oh my gosh, how cool is that? And so I did that. And I did my training for 4 years in San Francisco, University of California, San Francisco. And I loved San Francisco, loved delivering babies. But the more complicated it got, the more I realized I probably would have made a great midwife because I
Yeah.
love like the birth experience and that type of thing. But OBGYNs really, wow, they are dealing with some tough stuff and absolutely loved it. But got introduced to infertility kind of
Okay.
in my residency. So it wasn't one of these lifelong journeys. And I was like,
Right.
oh my gosh, this is amazing, incredible technology. I loved helping people through a really difficult emotional
Yeah.
time in life. And so studied that, and lo and behold, I had my own infertility journey. And I just thought that was really ironic. I
Yeah.
worked through a lot of anger. It's like, okay, a fertility doctor that doesn't know how to get pregnant.
Yes.
And then now I can't believe I've been practicing for almost 20 years
Wow.
and just truly love educating and trying to help people through that tough journey that
Yeah.
I shared. And you did too. I know that's one of the
Yes.
reasons we came together.
Absolutely. And
Hmm.
for anyone listening, I was telling Laura right before we started recording that with everything else, with endo and hysterectomy and breast cancer, I mean, I can say IVF ranks right up there with one of the hardest emotional things that I've gone through. I don't want to scare people off from the physical part necessarily, because to be honest, that's hard. But it wasn't as hard as so many things made it out to be. I mean, Dr. Google, like they make things sound really scary.
Yeah.
And it's doable, especially if you want a baby enough. Like the physical part's doable, but I definitely don't want to skirt past that emotional piece. And so it's so interesting what you said about anger. I just think that's spot on. Like those
And it's
emotions.
okay to feel that way. And I really appreciate your sharing that because you have gone through
Mhm.
endometriosis and pain and even breast cancer and
Yeah.
recovery. And just to share that IVF was difficult, I think that'll hopefully help any listener who is thinking about fertility treatment or maybe had their own experience already to sort of say, wow, I feel heard because I
Yeah.
think society thinks like, oh yeah, IVF is easy. It's like high tech
Yes.
and it's certainly crazy expensive. So it's just got to kind of always work. And yeah, there might be some shots, but I'm sure it's fine. And it's really so much more than that. So coming from you,
Yeah.
that really means a lot, Jessica.
Yeah. And I wonder, because that's so interesting, I think it is just a piece of women's health that maybe does get not sidelined, but like it's its own bubble a little bit. Like you said, it's that thought of, oh, designer babies, right? Like, oh, it just
Mhm.
is a way to choose, you get to choose a different path. And I will say it's not what I chose. I mean, thank goodness it was available. And thank goodness our son is here with us now. But it's not like, I don't think most people choose IVF to be the easy path
Absolutely.
necessarily.
Absolutely. And that kind of
Yeah,
is the same thing you think of like celebrities and having
right.
gestational carriers or surrogacy, and it's sort of portrayed as like, just a choice and like it's so easy and like people, might do it for superficial reasons or things like that.
Yeah,
Mm-mm. Most
right.
of my patients are very nervous, sort of reluctant, also can feel grateful, like you said, at the same
Yeah,
time, but it's not just a flippant decision or something that
right.
people take very lightly.
Right. And that's such a good point too around with women's health in general, right? Like I think that we probably feel that way with a lot of things now. The HRT discussion happening and perimenopause and everything, and even birth control. Oh, just this flippant, just I'll just make that choice. Or, a doctor just says, oh, just take this. It's no big deal. When really there's so much information that we need to make the right choice
Mhm.
and so much knowledge that we need and healthcare professionals willing to guide us to make those decisions.
Mhm.
So I guess around that, can you talk us through a little bit? Because I know that this could be a whole podcast series about hormones and infertility, but just kind of a general idea of what happens with our hormones
Mm-hmm.
for women, what we need for fertility, and what you tend to see, if there are any general things that come up, like, yeah, these are the things I see most,
Mm-hmm.
or maybe it's 100 different things you see that would cause infertility.
Yeah. Well, I think something really basic to start off with is that the word hormone has a really negative connotation.
Mm-hmm.
And it really is at its core just something that's made in one part of the body to talk to another part of the body. That's
Okay.
it. That's what a hormone is. And we're full of hormones. So our thyroid function is a hormone.
Right.
We ovulate with our bodies making hormones.
Mm-hmm.
And so I think when people think about hormones, they sometimes think about it like, oh, it's this negative thing and everything should be natural. And I think there's so many different ways I could go kind of talking about
Right.
this, but just that very basic definition, like, for example, we really have to ovulate in order to get pregnant and have a
Yeah.
baby. And so sometimes people are just not getting periods because they are not ovulating. And the reason they're not ovulating is that the hormone communication is out of alignment. The most common thing, 1 in 10 women will be diagnosed with a metabolic / hormonal condition called
Okay.
polycystic ovarian syndrome or
Mm-hmm.
PCOS. And so you can feel so frustrated. Like, why don't I just get periods and ovulate like my girlfriends? Why do
Mm-hmm.
I need help to make this happen? But really, it's just that the communication of your pituitary gland making these hormones called gonadotropins to talk to your ovary, to get your ovary to recruit an egg. And when that's happening, it's making another hormone called estrogen.
Mm-hmm.
And that estrogen needs to talk to the uterine lining to get it to get ready to implant. And then that estrogen also talks back to the pituitary gland to signal, hey, we've got a mature egg, let's ovulate. And then you got to have a different
Mm-hmm.
gonadotropin ovulate. So when you're checking for ovulation predictor kits, you're looking for a surge of a hormone called luteinizing hormone. And then that signals the release of the egg. And then after that, in the luteal phase, your ovaries are making progesterone, and that helps stabilize the uterine lining.
Mm-hmm.
So it is absolutely amazing that anyone has a regular, in air quotes, period, which means basically just about once a month. And it really is like a health checkup to know that your body is actually ovulating. You have to have to ovulate and then 2 weeks later get a period. If someone's having pretty predictable monthly cycles, I'm like, yeah, I can tell within like 98% accuracy you're
Okay.
ovulating most of the time. And so on the flip side, if someone is not ever sure when they're going to get a period or could go 2, 3, 6 months without a period, go see a doctor. Don't
Okay.
wait. Don't, like just, figure that out. So I think that understanding that basic knowledge, like
Mm-hmm.
one of the reasons people are so disheartened and frustrated by infertility is we are not taught in health class how our bodies work.
Yeah.
And then we are just convinced that we can control our fertility because
Mm-hmm.
contraception is so great that when we're ready to conceive, it's going to be so easy. And when it's not, you feel betrayed. You feel betrayed by your body, lack of knowledge, all of those things. But it could be something simple like helping just to get you to ovulate again. And we might use medications to help make that happen. So I know I went off on a lot of different tangents with
No,
that, Jessica, but I was just trying to kind of
I
really
think
teach
that's
a little bit.
awesome. No, that's so perfect. I truly believe, yeah, the more we know, the more we can at least advocate for ourselves and make the right choices. And how, if you were talking to someone, I know there's lots of information out there. So if a woman is listening to this, whatever her age, but she's saying, okay, we have been either, pre-trying, but trying to get her periods more predictable,
Mhm.
or trying to conceive and it's been a few months, do you have a general guideline that you tell people to say, you know what, after this amount of time, why don't you go see someone and let's just see what's going on?
Yeah, I would say about 6 months. And I know that in textbooks, they say if you are under the age of 35 and having regular predictable cycles, you should wait a year. And that if you're 35 or older, you should wait 6 months. I
Mhm.
just, I don't feel like there needs to be
Right.
a limit because just because someone's having regular cycles and they think that they're healthy, that doesn't mean that their partner has good sperm. And,
Right.
and you can't figure that out unless you do a semen analysis.
Yep.
So, honestly, it's like over 60% of people will conceive within the first 3 months of trying.
Wow.
And it's really 85% of people will conceive within a year of trying.
Okay.
And so that's where that kind of, wait a year comes in. And
Mm-hmm.
then the thought is if the eggs are older, that you should go sooner just because there is a shorter fertility potential as you're
Mm-hmm.
starting your family later in life. And you just don't want to miss anything like blocked fallopian tubes or significant
Mm-hmm.
sperm parameters. It doesn't mean that you're jumping to fertility treatment right away by seeing a doctor. The evaluation piece is just important to get that education and make sure all the parts are there so that you're not, like, in a kind of harsh way, wasting time. Like, I've
Right.
had people who have come to see me after years of doing
Yeah.
ovulation induction with Clomid or letrozole with a primary care doctor, and nobody's done a semen analysis,
Yeah.
So
Right.
it's just kind of advocating to sort of say, hey, I just want to make sure I'm not missing anything. And then you can decide what to do with that information.
Yep. I think that's so good. And I think it's really important too in this world, at least for me, it feels this way, online especially, that there is a lot of pressure to feel like you should do it naturally.
Mm-hmm.
And I felt that 8 years ago for sure. And I think even more so now, right? Like just eat the right way and decrease all your stress and do this workout and take this supplement. Like you should never have to go for medical help.
Mm-hmm.
Um, and I think they just work hand in hand. And I think that's so important to remember that absolutely there are things that you can do on your own at home. And also, if this is something that you really want and you want to commit to, see a doctor who's willing to listen to that, right? Like
Mm-hmm.
willing to do both with you. Hey,
Mm-hmm.
let's listen, let's do some tests, let's give you some guidance. And also, yeah, you can keep on this natural path. But to stay there for years, which is what a lot of us do sometimes, and then suddenly go. I mean, I can say, my story was getting pregnant naturally with our daughter and then secondary infertility, which is a whole other confusing kind of piece of, well, why can't I get pregnant now? And then, 2 years of trying to finally figure it out. My fallopian tube was blocked and there was nothing to be done about it. And luckily I had doctors on all sides guiding me, but absolutely it takes a few years to get that information. So if you
Mm-hmm.
can get some on the front end, I would think that just helps overall, whatever decision you're going to make.
Yeah, I feel like I really am disheartened in just a general feel in society that medical doctors are, you know, not thinking in their patient's best interest, or that you come to see a reproductive endocrinologist like me, that I'm just going to push, IVF as like
Yep.
the only option. And it's just really disheartening. And I'm sure that people do have really negative experiences with
Mm-hmm.
doctors, like, you know, asking questions and just sort of not getting answers. And I definitely think that uh, I was not taught a lot about what the way I practice now. Like
Mm-hmm.
I did not get a lecture on menopause in
Wow.
medical
Yeah.
school. I didn't get any really good nutrition learning in my medical practice. And Western medicine is very much focused on like what's broken and fix it,
Mm-hmm.
but you got to look at the whole person, and you can do both at the same time. You can do a anatomy evaluation to make sure that your uterus is great and ready for implantation, your fallopian tubes are open, and you can focus on nutrition and sleep and stress management and
Yep.
optimize your overall health. It doesn't have to be exclusive, and
Mm-hmm.
you just need to find that doctor that's going to partner with you, not tell you
Yep.
what to do or shame you for your choices, but education and kind of going through options.
And so, if a woman is kind of in this time or even wanting to get more information, who do you recommend that she seeks out? Would it be a reproductive endocrinologist? Would it be her PCP to start? Who is the best point of contact?
Yeah, it really depends on every situation. I think
Okay.
if someone has a primary care doctor or an OBGYN that they could start with and say, hey, I'm really trying to conceive, I want to make sure that the testing is okay, you can kind of look up online the regular tests to ask for,
Okay.
right? Like semen analysis, pelvic ultrasound, hysterosalpingogram to make sure the tubes are open,
Mm-hmm.
some hormone tests like thyroid, looking at egg count. You can figure out together the tests, and that could be a sort of a first step.
Okay.
But I will tell you, if you're able to see a reproductive endocrinologist, there's just not very many of us. And we're often
Mm-hmm.
sort of focused in pretty like metropolitan areas because that's just the nature of the practice. I wouldn't want you to delay getting testing just because you can't get in to see a reproductive endocrinologist. but also I wouldn't want you to delay too long staying with a primary care doctor or someone that really doesn't do fertility day in and day out, because if it's happening quickly, that is great. But I have seen people stay with their OBGYN for years and then just sort of say, I really wish I'd come to see you sooner. So it's got to be that right balance for that particular patient.
Okay. And I can say in each city that I've lived, I've had a reproductive endocrinologist because of my history. And it is absolutely someone who's given me more information than probably just about any other doctor I've seen. I mean, it is a great, great tool. So I agree, if there's someone that you can find, especially, and you can tell me if I'm right, but especially if you have a history such as endometriosis or PCOS. I have a prolactinoma, so I know that was a piece of my history. So if you have any piece of history that might be affecting this more, I would guess jumping to that point could be even more helpful.
Yeah. And I just think one thing that's pretty different is I think that in general, primary care doctors or primary OBGYNs are focused on the pregnancy that's happening right now. And reproductive endocrinologists are often using strategy to sort of think about what are your family goals? Because it's really different for someone who is 40 years old and wants to have 2 kids and they're starting, rather than someone who is 32, they have 2 kids and they're trying for baby number 3. Like there's just two totally different scenarios. And so certainly if you are starting your family after the age 37, 38, and it's not happening quickly, I think seeing a reproductive endocrinologist to get a full picture of what your options are and to meet your family goals, that's another little kind of caveat that's important to think about.
That's a great point. That's a really good point. And then what have you seen more women in the past few years asking about freezing their eggs? I would love to hear your experience on that. I was just in a business meeting with a couple girls in their early 30s, one of which has, and another of which was just talking about all of her friends who are. So I would love to know just your experience around that right now.
Yeah, absolutely. And one of the coolest things about being in a field for 20 years is to see a dramatic change in technology that keeps options open for people. And so, yes, I have seen a dramatic increase in my career. You know, I mean, you can go back a couple of decades and think about the first egg that was frozen, but really it wasn't until 2012 that the American Society of Reproductive Medicine lifted the experimental label of egg freezing. So it used to really just be focused on maybe cancer patients that were going to lose their fertility with radiation, chemotherapy, or, surgery, and trying to somehow preserve their fertility before going into cancer treatment. But there just wasn't a lot of long-term data. And so ASRM really kind of opened up the opportunity for people to do it for a lot of different reasons in 2012. And so since then, it's just gotten more and more popular and available.
Okay. And do you have a recommendation that you make to women at all who want to start a family but don't feel ready? Is there some magic age that they are looking at to freeze by, or is it really just case by case personal
Yeah,
decision?
I believe it is case by case, because sometimes people have chronic illnesses like endometriosis or something that might impact their fertility, so they might want to freeze eggs sooner. Sometimes people just have access to care in a different way. Studies have tried to look at the cost-effective balance, because the younger you are when you freeze your eggs, the better the eggs are. So age is a huge predictor of fertility. That's the whole point of freezing eggs. Younger eggs are able to do all the genetic work that they need to better than older eggs. So you're trying to freeze, the fertility of your younger years on those eggs. But when you freeze your eggs really young, like in your 20s, there's a lower likelihood of actually needing them or using them, because you have so many fertile years, typically, not for everyone, but so many fertile years ahead of you, that you might be paying for storage for a long time, or you might just not even use the eggs. And so people say, gosh, was it really worth it? Now, this is statistics, this is economics, kind of looking at it. And I haven't met someone who has regretted freezing their eggs, no matter how long they paid for storage. It can relieve a little bit of this biological clock stress. Like, you're maybe in your mid 30s, and then you're like, well, I meet someone and maybe we date for a year, we're engaged for a year, and then we don't want to try for a year. Oh my gosh, I'm starting my family at 38, 39. So it's just, but this cost benefit analysis has sort of said really your mid 30s is a time where if you have not started your family and you really want to think about it, like that's a great time to do it.
Okay.
But I just want to emphasize, you never know what your egg supply is going to be like in your mid 30s. That is just based on age. And truly, the younger the eggs are, the better they work.
Yep. I will say I knew that. Like I knew that knowledge. So I got pregnant with our daughter at 35 and then our son at 39. And yeah, I did know that, but I didn't know it, right? Like until
Oh,
you're in the
yeah.
middle of it and you say, oh, this would have been easier had I have started earlier. But also, that wasn't my story. Like I wasn't ready to start earlier. So it's just such a balance, and everybody really is so different, and you don't know where you're going to be in the future.
Totally.
You just don't. You can make the very best choices in that day, right? Like that's the best we
Absolutely.
can do. Yeah.
I totally agree. Yeah, I think it is so hard. I mean, I really try to relieve the burden when my patients just sort of say, gosh, I wish I'd frozen my eggs, in the past, or I wish I'd started sooner. I'm like, we all make the best decisions in the present moment. And if you had started trying to conceive and had 2 kids with ease, you would look back, you wouldn't even think about those previous choices. So just, it's like, we're all just doing the best that we can.
Absolutely. Absolutely. So I would love to talk about, because I know you gave us, I love the hormone kind of talk, the 101, hormone 101 that you gave us. So going past, because I know you're a fertility doctor, but obviously you have information and you see people on all spectrums of life. So what kind of happens just from that hormone perspective when we start to reach perimenopause and when we start to go into menopause?
Yeah. So much,
Yeah.
so much.
Everything.
Everything. But as a fertility perspective, I sort of
Yeah.
say, well, the ovaries get less predictable.
Yeah.
And there are fewer good eggs, just no matter who you are, the most you can ovulate is 12 to 13 times in a year. And when we're 25, most of those eggs are going to work just fine. When we're 45, maybe one, and there's just so many things that have to go right to conceive. And so what people can often see as their egg supply is dwindling and hormones are changing, they can see changes in their periods. That can be really common, where all of a sudden ovulation is a little bit less predictable and people can skip a cycle or not. Or what sometimes people will see is a shortening of their cycle. So the hormones, the gonadotropins, the follicle stimulating hormone is kind of the gas to tell the ovary to go and recruit and ovulate that egg. And as we get closer and closer to perimenopause and menopause, it requires more gas or higher FSH levels to get the ovary to ovulate and do what it needs to do. And that can result in like a shorter time from recruiting an egg to ovulation. So someone could say, hey, my periods used to always be 28, 29 days, from start to start. And now they're 24, 25, or I'm skipping a cycle, or all of a sudden they're 21 days. So that shortening can be a little sign of perimenopause. With the irregular ovulation, the ovaries aren't making as much estrogen. And it's the lack of estrogen that is usually the reason that people have so many of these perimenopausal symptoms. So if you're not ovulating regularly, you're skipping cycles, it's just like a little bit chaotic or a little bit unpredictable, and no matter what language you want to use, your body is not seeing as much estrogen. And that could result in many things. It can result in difficulty sleeping. It can result in night sweats or hot flashes. It can result in increased musculoskeletal issues. If you heard of like frozen shoulder of menopause, it can result in vaginal dryness, low libido, lack of interest in being intimate. it can result in losing bone mass and being more likely to have breaks, and osteoporosis. Like there's so many things that come along with having that lower estrogen, lack of predictability, and kind of getting to the point where you're running out of eggs.
Yeah. Yep. And I love on your website, because it's not common with IVF and fertility doctors, your passion around endocrine disruptors.
Mm-hmm.
And I'm going to let you tell everyone what that is. I don't want to confuse everyone, but I would love if you would talk to us about that, because that really that would affect women leading up to fertility. It would affect regular periods. And then it affects those of us in perimenopause who are done having babies, and even into menopause when we talk about, just like you said, losing estrogen. So how can we naturally support the estrogen that we have? So will you talk to us about endocrine disruptors, what they are, and then how we can look for those in our own environment?
Great. So one little piece I'll just pull out is really there's a real trend to understanding that around perimenopause and menopause, it is okay to replace the hormones that you've lost, like whether it's estrogen or testosterone. And there's lots of different ways to talk about that.
Yes.
But that really is an amazing way to relieve the symptoms. And a lot of the studies that came out when I was at UCSF, those, WHI studies, the headlines scared people about estrogen replacement. And the actual studies did not show this fear of breast cancer. So I just wanted to piece that apart.
Yes,
now,
please. And for those of you listening too, so the people who did the study that made everyone afraid of estrogen, they have even come out and said this wasn't a well done study and it wasn't interpreted correctly. So yes, talk to your functional medicine doctor, talk to the doctors in your life, but wholeheartedly agree that HRT has a place for those of us perimenopause, menopause. It can have a really important place as a part of a multifaceted approach.
Yeah, that was such I don't know if I can say this in your podcast, but a shit show. I remember.
You can say anything on this podcast.
Well, because it has harmed a generation of women, including, women in my family. Because the journalists got a hold of this, and before anyone in the medical field could even read the raw data, and basically said, we're stopping this big, huge trial to, because there was a slightly higher increased risk of breast cancer in some of the people that were taking estrogen and progesterone. And all the medical field knew was that, wow, the trials were stopped and it was on the news. And then when you got the data and you really went through it, you're like, wow, well, they're actually looking at women who are 65 years old, 75 years old, way past menopause, and they're trying to give them estrogen and progesterone to decrease cardiovascular disease. And maybe just a very small percentage actually had some breast cancer be diagnosed. And anyway, so it's just that is where we have to be so careful with headlines and news and medical stuff being reported, because there's so much nuance. So
much nuance.
Okay, to move on.
Is done. And what kind of hormones they used. I believe they used synthetics. They didn't even use bioidenticals in that study. So again, this isn't us saying, yes, you're absolutely the right candidate for it, but knowing that it is a open and important discussion to have.
Yes.
With your healthcare provider, because there are options. And if you have a healthcare provider who shuts that discussion down, I recommend finding someone who at least can read the data with you and have a discussion with you about it. Like even I'm someone who has had breast cancer, and my oncologist, one of the first things she told me was I might still be a candidate someday if I was interested in HRT and estrogen. And she would have that discussion with me depending on my symptoms. But just knowing that door was open and she was willing to look at all the research with me was so important.
Yeah. So absolutely, because you don't have to suffer. I really believe that. So endocrine disruptors are, the way I think about it is they're really chemicals, like man-made substances that act like hormones, and another word for hormone is endocrine. So they act like hormones in our body, and it disrupts the natural communication of hormones in our body. So there's a lot of chemicals in our environment that basically act like estrogen, or they act like testosterone, and they can throw off a lot of the natural systems. And so a really common one to think about is bisphenol A or BPA. Like a lot of people have heard of that. They know that they can get water bottles without BPA, and they're like, oh yeah, I've heard of that. I can wrap my head around that. So the reason that is such an interesting example, and there are hundreds, thousands of endocrine disruptors, but BPA is one we've heard of. So let's focus on that for a second. BPA was actually created early in the 1900s as an estrogen supplement or replacement. And so it was actually created as a pharmaceutical to give to women to help with a lot of different things like miscarriage or menopause support, et cetera. And it was only taken off of the pharmaceutical shelf and replaced with something called DES or diethylstilbestrol, because that works so much better on attaching to the receptors and acting like estrogen and the hormones. And what's really shocking about that is DES is no longer available in the United States or around the world because since 1974, when they realized that women who took DES in pregnancy, the daughters and sons that were born had increased risk of cancer, specifically vaginal clear cell carcinoma and uterine malformations and ongoing issues. So in my field, it's like, yeah, you always know DES is something that, this is why we're so careful about giving different medications to people in pregnancy, because sometimes we don't know until the next generation something that happens. So that knowledge that it is BPA was actually a pharmaceutical, it acts like estrogen. They realized, actually, if you use BPA in plastics, it's a great plasticizer. It kind of makes plastics a little bit more flexible, a little bit more durable. They work great, but unfortunately, BPA can leak from the plastics into whatever you're, drinking water or food if, containers have that chemical. And so it was getting into our systems, and BPA has been linked with increased risk of miscarriage and poor IVF outcomes, poor egg quality, poor sperm quality, et cetera. So that is just one example. And what I tell my patients is, yes, it's great to get something that's BPA free, but really let's focus on just not having as much plastic exposure as we can, because I say there's BPA through Z. So even if something doesn't have BPA in it, it could have BPS or a lot of other chemicals that are still really kind of disrupting that pathway.
Wow. And I'm guessing this goes with when we talk about removing the toxins from our cleaners and organic meat products and all of those things.
Right. Yeah. And it's really overwhelming when you first learn about this. The first time I ever heard about BPA was one of my last lectures as a fellow at Stanford. And then I just went on about my business and was a fertility doctor. And then it's really my patients that started asking me about it. And I started really looking at a lot of the research. There's much more research in Europe and other parts of the world than the United States on endocrine disruptors. It's like, wow, this is really something to pay attention to. I really did a deep dive. I wanted to research, my books on the topic of miscarriage and fertility because I wanted to make sure I get this right. And I went to a really dark place. I was like, okay, we're all poisoned every single day. That's it. I'm just like, it's kind of like climate change. When you really sit in it for a while and think about it, you're like, how can I even care? It just feels so bad. So I try to tell people a couple of things. Number one, you cannot eliminate all your exposure to microplastics and BPA and phthalates and parabens and all these things. But our bodies do a pretty amazing job that if we decrease the exposure, you can pretty quickly see lower levels in your system. And it's really people with the very high levels in the studies that have been associated with a poor reproductive outcome. So don't get overwhelmed and just shut down and ignore it, but just make really solid choices in your everyday life that can decrease exposure, and you're going to do great.
Okay. And I love that too, like the skincare piece. So avoiding parabens. And I feel like it's a lot easier now than it was 20 years ago. I mean, there's so many products, even your favorite shampoo, you can probably find that they've made one without parabens in it.
Yeah, exactly. I think, and I also tell my patients like, okay, well, one solid thing you can do is like, let's think about getting plastics away from our food. So it's like, try not to use a plastic water bottle. Use like a glass one or stainless steel. Don't use plastic food storage containers. Get glass ones. They last a
Yep.
lot longer. They're actually easier to clean.
Yep.
And even just like takeout, right? Like when it comes home, just get it in a different container that isn't going to be leaking kind of all the chemicals into the food. Don't
Okay.
heat your food in plastic. Like if you're going
Yes.
to put it in the microwave, like put it in a non-plastic container. Don't put plastic containers in a dishwasher because it gets really,
Mm.
really hot. So it's like heat and plastic and food. Try
Yeah.
to eliminate that if at all
Okay.
possible. And then
Okay.
for beauty products and household products like laundry detergent, things like that, I mean, it can be really expensive just to like
Yeah.
throw everything out. So just like, okay, just take it one product at a time. You finish
Yeah.
your shampoo, take a look at it, learn about
Mm-hmm.
it, do a little research on it, and see if there is an alternative that is going to be less toxic. And it doesn't have to be every single product.
Mm-hmm.
You might have this one shampoo that just absolutely works for your hair. That's great. Okay, but women especially can
Yeah.
put on like 20 different products with like makeup and with on
Mm-hmm.
your laundry, and your hair. And so if you can think about other products, that's great. And a really basic thing, just forget fragrance. Like fragrance is code word for phthalates and
Mm-hmm.
parabens, and companies can hide behind it. So if you see fragrance as an ingredient, that's like code word for we probably got something in here we don't want to tell you about because it is trademarked. And so companies can sort of say, oh, well, if this chemical is involved in our fragrance, that is proprietary. And we don't want other companies to figure out how we're getting this fragrance. And so we don't have to tell the consumers what actually are the chemicals that are making up the fragrance. So even just the basics of like fragrance-free laundry detergent,
Mm-hmm.
our clothes are not supposed to smell like a mountain stream. What
Yeah.
is that?
I
Like,
don't
or a
know.
mountain breeze. What is that?
Yeah.
So just little thoughts. Or if you do really like those smells, you can get essential oils and put them on little wool balls,
Yes.
in the dryer. And that can make your clothes smell great, but they're not exposing you to the, endocrine disruptors that we're talking about.
Yes. No, I think that's so great. And that is something like throughout our lifespan that really all of us should be doing because,
Yeah.
yes, whether we're trying to get pregnant or we're past fertility years, we all still have an endocrine system. I mean, it's what runs
Yeah.
everything. Our hormones run everything. Like, I think we've broken it down to estrogen, progesterone, and occasionally we talk about testosterone. But like you said, and we're talking thyroid, we're talking about cortisol, our entire body runs on hormones. And so instead of
Absolutely.
giving them a bad rap, let's find ways to nourish them because we need them,
Yeah.
right? Like we need them.
Absolutely. No, and
Um,
amazing studies show lower levels of parabens and phthalates can improve endometriosis symptoms.
wow.
Yeah, endometriosis in general is inflamed by
Yeah.
estrogen and sort of quieted by
Yes.
progesterone. So a lot of these chemicals that are really estrogen-like can really make our symptoms worse.
Yep. And that, not to go off on a whole side note, but I love that because I have found that for myself working with someone who had talked, because again, it's general, right? The general thought is in perimenopause, your estrogen goes down, so you need more. And so I think a lot of us take that when in actuality, our estrogen goes up, down, up, down, up, down during perimenopause. So if people are just taking that general idea of, oh, I just need more estrogen. Okay, I'll just take more. And I did that at one point and wondered why my endo flared so
Mm.
badly at the age of 46. I'm like, oh, that would be it. Because endo really does not like estrogen. Oh my goodness. And so again, it just goes back to we are all different. Like,
Mhm.
yes, we all have hormones. Yes, in general, this is what's happening. But yeah, what are your family goals or what are your life goals or how do you feel or what do you need? And find a healthcare professional who is willing to look at you as that individual. And I really think you just promote that idea so
Mm.
much. And so one other thing I really wanted to touch on is on your website, you talk about shattering stigmas. Like it
Mhm.
really is such a value of yours. And I know that's fertility. I know it's miscarriage. So can you talk to us a little bit about that? Like either where that comes from or what kind of vision that is for you
Mhm.
and why that's so important to you.
Yeah, I would say it first started with just counseling women over and over and over again that infertility and miscarriage is not their fault.
Mm,
And just shattering that stigma that anything that has to do with family building, if it's not going well, has got to be the woman's fault. And so genetics have really shown us that the vast majority of miscarriages are from an embryo issue and a genetic chromosome dysfunction or other genetic issue within the embryo, not the anything that the person who's getting pregnant is doing wrong. And so just relieving that burden is really important. And this goes to men too. Like, we can't assume that sperm is okay just because someone's had a baby in the past. We can't assume that because someone doesn't have symptoms like erectile dysfunction or difficulty trying, that they have a normal sperm count. So until you look under the microscope, you can't be sure that there's not a male factor. And honestly, up to 50% of the time, there is some component of male factor in an infertile couple.
Wow.
So those are big stigmas just to reshape and allow people to just stop carrying around that shame, because we're fortunately learning more and more every day.
Wow, that's so amazing. And tell us, that leads right to your book. I would love for you to talk. We didn't talk a lot about miscarriage today, such an important topic. So tell us about your book too.
Oh, thanks. Well, the title of it is Not Broken, an approachable guide to miscarriage and recurrent pregnancy loss, because I truly believe, women come to me feeling broken. Like, I'm getting pregnant. I can't stay pregnant. My body is rejecting this perfect embryo or baby. I know I'm doing something wrong, and I feel broken. And I would find myself saying it over and over again. You are not broken. You're not broken. Let's do testing just to make sure we're not missing anything that we can control. But most people who are having miscarriages are going to get pregnant and have a baby, because think about all of the things that are going right. They're ovulating. Their egg and sperm like each other. Fertilization is happening. Implantation is happening. And then that pregnancy is just not continuing, most likely from a chromosomal issue or a genetic issue. And so every time they get pregnant, it's a new opportunity. Now, that doesn't mean that we don't have things that we can offer. And if we do find something like a thyroid issue or an anatomic issue, we can decrease the risk of miscarriage. But that is a really, really important part of that book, because I think so many people carry around shame. And I just want people to be able to go to their doctor and be able to say, hey, I keep having miscarriages. These are the tests that I want to do, because a lot of primary OBGYNs and primary care doctors haven't had any teaching on recurrent miscarriage. Like 10, 15 years ago, the definition of recurrent miscarriage was 3 clinical or sort of further along miscarriages. Well, that has changed. If someone has more than 1 miscarriage, even if it's really early along, you should absolutely offer testing for them. But there's still doctors out there that say, oh, it doesn't matter until you've had 3. And the people hearing that are like, what? It matters to me. And why wait until a 3rd miscarriage to find out that there's a thyroid issue that we could control for? So that is, it's meant to be helpful and help people advocate for their care. And, there's so many controversies in care for miscarriage because we're still learning so much. So there's a lot of, immune testing and treatment that's out there that's really not well-founded in evidence. And so just I'm trying to have a very open discussion about, hey, you might read about this on the internet, or your friend might have had this intervention and might have, had a baby, but is it really that intervention, or is it really just that they finally got pregnant with the right embryo? And so just pros and cons of because there is an intervention out there, it doesn't mean that it's right for you. And there's always side effects with every intervention. So pros and cons, and sharing both sides to a lot of the controversies in miscarriage. That's one of the things I'm really proud of in that book. Not trying to tell people what to do, but sort of say, hey, you could hear this. This is where it comes from. This is pros. These are cons. And I just really hope that's helpful.
Oh, I know it will be. And I think, yes, if that's you listening, or if you have a daughter who has gone through this, I think it would be such a valuable resource. To sift through it. And I think just to know that that person isn't alone. Like
Yeah.
really, I think that's such a huge thing. It can be so isolating. So
Thank you.
thank you for that. And tell everybody where they can find you. Like, where's the best place to find you?
Absolutely. Well, my website, drlorashahine.com, has links to my books and my podcasts. And I'm doing the most probably educational content on YouTube because that's where I can give long form content. I love TikTok and I love Instagram for short little nuggets, but really teaching is on my YouTube channel. And then I also love hosting a podcast, the Brave and Curious podcast. And you have been a guest. That was an excellent episode. I think that was my first season. You're amazing. But just interviewing people that have been through it, interviewing experts in the field, doing deep dives. So I truly love educating, and I just have lots of different ways, books, podcasts, YouTube, because I think people learn in different ways.
Agreed. And we'll have all those links below. And I just can't emphasize enough that, yes, if you want someone who combines knowledge with hope, this is where you need to go. Pretty much everything you post, I'm like, how many times can I like this? And yes, those are my words. So I am so thankful that you were here today. Thanks for coming on, and thank you for everything that you do.
It's an honor. Thank you so much for having me, Jessica. It was really good. Good to connect.
Bye.
Bye.
Thanks so much for listening today. I would love it if you could take a moment to subscribe, rate, and review this podcast. It means a lot to us, and it helps our content get out to more women who need it. You can find more of my resources at my website, jessicavallant.com, or find me on YouTube at Jessica Vallant and Instagram at Jessica S. Vallant.